Hello and welcome to another webinar presented by Vertical Aviation International, VAI. I'm your host, I'm Chuck Street. I'm the VAI U.S. Western Region representative for the organization, and it is my privilege today to interview our distinguished guest. The title of this webinar is called Prepare for Your Medical Like It's a Check Ride. And many of us have been through a lot of check rides, and some of us have probably been through quite a few medical exams too. I wanted to read the preamble really quickly about this, and here it is. Everyday pilots are denied their FAA medicals simply because they aren't properly prepared or don't understand what makes them physically unfit for flight. So that's what we're going to be talking about today. And I think the information provided is going to be very, very useful. By the way, you'll have an opportunity to ask questions and make comments towards the end of our presentation. And you'll probably see at the bottom of your Zoom screen, there's a Q&A button. So you can click on that and then ask your question or make a comment. So I wanted to introduce our special guest who has a very impressive resume, and that's Dr. Keith Roxo. And I just wanted to talk a little bit about his background. He's the operations director at Wingman Med. He's a Top Gun trained adversary pilot who has flown the F-18, the F-16, and the F-5. He has his ATP and CFI MEI. He is also board certified in both aerospace medicine and occupational medicine, and is a HIMS qualified senior AME for the FAA. So welcome, Dr. Roxo. We're really honored to have you with us today. And again, can you comment a little bit about, you said Top Gun when you were in the Navy?
Yeah, so I started my career off in the Navy as an F-18 pilot, went through the normal training pipelines, did my first tour. And then after that, I did go to Fallon, Nevada to be a member of the Air Wing training staff, teaching all of the Air Wings before they go out on deployment. And, my specialty was to play bad guy. And so Top Gun has 3 courses, or at least they did, 20 years ago when I went through, that kind of run simultaneously. There's what they call the Strike Fighter Tactics Instructor, and that's the members who are fighting on our side and doing, what we call the good guy tactics and specializing in that. And then there's the controller course. So there's the folks who are learning how to be an elite controller for tactical aviation, and those would come from either the Aegis cruisers, or they would come from the E-2 Hawkeyes. And then you also had the folks like me who were the adversary, how to play professional bad guy in order to help train, the fleet. And that's what I did.
Okay, well, it's certainly more than a video game. It's the real deal, right?
Yes, it is. And that's why I've flown the F-16 and the F-5, because the Navy tends to use those as adversary aircraft.
Okay. Well, you have an excellent PowerPoint presentation, so let's get started. Let's talk about our topic. And again, I'm really looking forward to the information that you have to share with us today.
Thank you very much. All right, let's go to the next slide, please. So one of the things we're going to talk about is that when you go in for an FAA medical certification exam, there's 3 possible outcomes. You can either receive your certificate, be denied your certificate, which is rare, or you can have your exam be deferred for further review by the FAA. The FAA processes over 400,000 medical applications a year. And across the nation, about 6 to 9% of the exams are deferred every year. And so that means you're not getting your certificate if you are deferred. So that's about 25 to 35,000 exams that are deferred, every year. And if your exam is deferred, it can take around 6 to 9 months to get your medical. About 1% of exams are denied every year. And from our experience, what we see is that the vast majority of people whose exams are denied, it's not necessarily because they're not medically qualified, but it's because they could not show the FAA that they are medically qualified. So today we're going to talk about, why the exam exists and how to approach it. We're going to talk about how you need to fill out MedExpress to minimize the number of questions you're going to get from the AME or the FAA, and to eliminate confusion as much as possible. We're going to talk about the importance of proper medical documentation, how to get a note from a doctor, particularly if you're having some trouble with it. We're going to talk about an example client story that we refer to here as the horror story. And then finally, we're going to talk about how to just approach your exam in general to minimize the chances of deferment and maximize the chances of getting it as quickly as possible, getting that certificate as quickly as possible. Now, next slide, please. So for the exam, one of the key things that takes some pilots a little while to understand is that going to the AME is not the same thing as going to your regular doctor as a checkup. It is an examination. It is an independent examination, and it needs to be treated just like any other examination or test, or in pilot parlance, a check ride. And that's kind of what our motto is, right? Treat that medical exam like a check ride. The purpose is to establish your suitability to fly for a specific period of time, given the level of responsibility that you are requesting. And that corresponds with the first, second, and third class and the various durations that they are based on your age. So with that, it needs to be treated like a certificate. In fact, the medical is a certificate, just like your pilot certificate. And now it's the only one with an actual expiration date. So it's important to be able to renew that in a timely fashion, particularly if you are employed or you have a lot of money tied up in aviation assets like your own aircraft. So how many people show up to a commercial pilot check ride or an annual Part 135 line check completely unprepared? Not many, but when we see or when we talk to a lot of people, they just showed up to the AME completely unprepared for that medical, and then they get upset with the FAA at the duration it takes. But if you think about it, if you showed up to your commercial pilot check ride completely unprepared and your DPE failed you on that check ride, would you be upset at the FAA for that? That wouldn't make a lot of sense. So for the FAA or an AME by designation, to determine your suitability to fly, they must be aware of all of your medical conditions. And Title 18 of the US Code sets forth both the requirement to be truthful and possible sentencing for falsification. Next slide, please. People will often ask us, why does the FAA think that they are entitled to this information? And in truth, the FAA is absolutely not entitled to this information. But similarly, there is no constitutional protection to fly. So you are not entitled to fly. In the United States, what we have is a set of regulations that govern who is allowed to fly under what type of rules. And part of those regulations include a medical certificate when you're looking at first or second or third class privileges. And so while the FAA doesn't have a right to know, you also don't have a right to a medical certificate. Specifically, when it comes to HIPAA, there are questions that people have about, isn't this HIPAA protected? And the answer is no. There's multiple reasons why HIPAA is not protected in this situation. One is that you are required to disclose by federal law, and HIPAA does not protect your medical information if you choose to disclose it. You can always choose to not disclose, but similarly, you're going to choose to not get a medical certificate in that situation. Meanwhile, the relationship between the AME and the pilot is exactly the same as the DPE and the pilot. They are an evaluator. The AME is not acting as your treating physician, and therefore there is no doctor-patient relationship, so the information coming out of that exam is not protected by HIPAA. For folks that work in other industries, like police, fire, there's forklift drivers, there's people who work with hazardous chemicals. They also have to go to routine examinations, usually governed by OSHA as opposed to the FAA, and they have very specific requirements and durations as well. So this is not novel to aviation. It's just the one that you might be most familiar with. Next slide. Pilots old enough to remember the paper application that we see on the screen here, may realize that when you fill out the digital version of MedExpress, it's really just completing a digital version of the 8500-8 in the PDF version. In fact, when you complete your MedExpress submission, you have an option to download a PDF copy to retain for your records. Now, I highly recommend that you do that. As of right now, MedExpress does not save your answers from the previous year. That is unfortunate, but that's the situation that we're in. We do know that they are actively working to change that. However, as of right now, MedExpress does not save your answers from your past submission. That is why saving a copy of that 8500-8 is a good idea. Keep that in a cloud folder so you can reference it on your phone or your tablet or your laptop or whatever. And that way, the next time you're filling it out, you can just use your past one as a guide. Now, there are several sections, but the goal is essentially to capture a complete picture of your medical history. The FAA could simply say, tell me about your medical history, but they know that you're going to forget things, and that's okay. That's just the way things are. I will frequently ask patients in my clinic, hey, do you have any medical conditions? No. What medications are you taking? And they'll rattle off 3 or 4 medications. Okay, well, now I know you have 3 or 4 medical conditions that you take medications for. So they will ask these questions to jog your memory. They're going to ask about medications, medical conditions, questions about military service, life insurance, and what medical professionals you've seen in the last few years. And all of these questions are designed to be triggers to help you remember the various medical conditions that you have. Next slide. Medications are pretty straightforward. If you're taking something, you need to list it. If you're not taking it, you don't need to list it. Now, don't not take it that morning just so you don't have to list it. That's not a fair play. But if you took something 8 months ago, you don't need to list it today. And that'll come up later in our horror story as well. You may feel fine on some of these over-the-counter medications. And yes, you do have to list over-the-counter medications, but like the picture we have up on the screen of Benadryl, Benadryl actually has a longer mandatory wait period due to fatigue than many prescription sleep aids. And so it's very important to understand that just because something is an over-the-counter medication does not mean it's actually safe. What you don't want to be doing is dealing with a cognitive impact of a medication when you are at a higher altitude and the oxygen percentage starts to drop and the demand increases because you just lost your autopilot as you went into IFR conditions. That's not where you want to find out that you are no longer operating at 100%. Over the years, the FAA and the NTSB have published data that a growing percentage of pilots involved in fatal accidents have had potentially impairing drugs, be they illegal, prescription, or over-the-counter, in their system on autopsy. In fact, at the end of a 5-year study in 2017, 28% of pilots who were involved in fatal accidents were positive for a potentially impairing medication. Next slide. After medications, the FAA asks about very specific medical conditions. There's a statement right there in MedExpress that starts off with, have you ever in your life? Now that can be a very long time for some of us. This is one reason why we recommend keeping copies of those past submissions so that you can just update it as you go. But the FAA is primarily concerned about the risk of sudden or insidious incapacitation in flight. So sometimes a pilot will say something like, I didn't tell the FAA about my sleep apnea because they didn't ask for it. Well, actually they did. At the end of that series of questions is another one that says any other illness, disability, or surgery. So that's kind of their catch-all for things that are not specifically addressed. The ones that they specifically ask about are those highest concern for sudden or insidious incapacitation. That doesn't mean that those are the only things that they want to know about. Taken all together with the introductory statement, it should be obvious that the FAA is asking, have you ever in your life had any illness, disability, or surgery? Once you get done with those specific questions, there'll be more memory jogging questions about discharge from the military for medical reasons, rejection from military service, rejection from life or health insurance, and receipt of disability benefits. After that, they're going to move on to questions about drug and alcohol use, as well as criminal history. Lastly, you're going to be asked to list all of your medical appointments in the past 3 years. Next slide. When you're filling out MedExpress, you want to tell a consistent story and you want to be as concise as possible, but you need to have meaningful answers in order to make that interaction with the AME and FAA as smooth as possible. What you don't want to do is show up to that exam and make it very confusing for the AME. The more confused the AME is, the more likely your exam is going to be deferred, whether it should be deferred or not. So you want to put your best foot forward. Some examples of being consistent. If you list Allegra and Flonase as medications, then you need to mark yes on question 18E for hay fever or allergy. Zyrtec, by the way, is a common over-the-counter antihistamine, and it is disqualifying for regular use. If you mark no to all the medical condition questions, but then mark yes to a military medical rejection or disability benefits, that's not going to add up. You must have had some medical condition to be rejected from the military or to have disability benefits. If you mark no to question 18G about heart or vascular trouble, but you list 5 trips to the cardiologist in the preceding 6 months, that's going to spark some questions from your AME. And so it's better to have that information already in there. After your answers have been submitted in MedExpress, you can't edit them. Once you hit submit, that's it, you're done. The AME, however, does have the ability to update those answers. So if you made some minor errors on reflection, that's okay. The AME can fix those in the exam, and he just has to document why it was corrected. If you think you've made some major errors and you have the time available, you can just let it go. After 60 days from submission, it will just delete in the FAA system, and you can start a brand new one. But you do want to ensure that you're making that clear and consistent story to have that smoother process with the AME and the FAA. Next slide. These are some tips that we like to use. Overall, you want to have a corresponding medical condition for every medication you take and disability that you have. If there isn't a specific question about your medical condition, that goes in that catch-all, any other illness, disability, or surgery. You want to provide a brief statement about each medical condition, but you want to keep it to about 1 sentence. If you can't make it a concise 1-sentence statement, then you really need to start considering, I probably need to get a more comprehensive note from my doctor about this issue. When you list all of the appointments, you need to have a reason for them. In fact, you can, sometimes people say, well, I'm running out of space, like, because I've had so many appointments. If you've had a major thing that went on and you had multiple appointments associated with this, you can summarize all of those appointments in 1 line. They don't all have to be listed individually. Something that we commonly see, and unfortunately is still in the MedExpress instructions, is that if you have previously reported something, you can write previously reported no change if there has in fact been no change. However, do yourself a favor and don't do that. The reason is that most AMEs are not going to be able to see your complete exam history. They can see the previous exams that they have submitted. Otherwise, they're only going to get a short summary of the more important items. So if you go to a new AME and you say that an issue is previously reported and no change, they don't actually know that you've previously reported that. And they are not allowed to submit that to the FAA with previously reported no change. The FAA will kick that back and say, you didn't give us enough information. So the best way to do that is to be as specific as possible, right? So let's say you had a car accident and you punctured a lung, and that was 5 years ago, and you previously reported it, and you got through all the process, and the FAA cleared you. So what you're going to say is, on lung issues, you're going to put traumatic pneumothorax from car accident in 2020, previously reported on exam in November 2020, no change. Issued medical after review, no change. So that simple sentence is going to give that new AME a pretty good feeling that, okay, that's a reasonable story. This guy's probably not making that up. And then if they do want some more information, they can always call the FAA to confirm that. But the more information you give them, but again, as concisely as possible, the better it is. And then again, retain those copies for your future reference. Next slide. We see more problems with documentation than you can probably imagine. And this is where it highlights the importance of the medical documentation. Going back to that statement where I said, if you can't summarize it in 1 sentence, it's probably time to get a current detailed clinical progress note. So what is that? Next slide. Current means within 90 days of your exam. Now, let's assume for the sake of this discussion that you are preparing for a new exam. That means when you go to that exam, if you're going to bring paperwork to discuss any medical conditions that you have, it needs to be no older than 90 days. Now, some people ask, well, what's the magic about 90 days? Well, the important thing to remember is the FAA is not certifying you for your medical for life. They're certifying you for a very specific period of time. Many medical conditions can be chronic in nature. And so they want something current for that evaluation. And they don't want something that's 5, 6, 7 years old. They want to know how you're doing right now, particularly for those chronic medical conditions that can wax and wane over time. So what that means is if you know that you need to see multiple doctors, you need to plan out in advance how to schedule those so that nothing is older than 90 days. Now, what about detailed? Next slide. Here are a couple of examples that say similar things. One is just very simple, hypertension controlled with prescription medication. Now, many times this is something that a doctor will write because they are simply updating their previous note about you, and that if you go far back enough in history, you will get all of the information. The FAA doesn't have all of your history. They want one note that says how you're doing. So with that, something that is a little bit more specific and a little bit more detailed, such as the bottom part, is what the FAA is going to want. They're going to want to know what medication you're on, why you're on it, were other things considered, are there any side effects, and how you and what the plan is for the future. Those are very important elements of that clinical detailed progress note. Next slide. So on this slide, these are all of the elements of a detailed clinical progress note. I'm not going to read them for you here. You can go back and watch this later and pause it. You can also go to Google and just Google search, or any web browser, search for FAA detailed clinical progress note. And I believe it's a 2-page PDF that is hyper detailed in exactly what they're looking for. That is always something you can bring. Now, this classically follows the type of notes that doctors were trained to write in medical school. But medical school style notes are kind of falling out of favor when it comes to the rapid pace of medical care, where you've got one patient every 15 to 20 minutes. And with the use of the electronic health records, you're just, like I mentioned before, really just updating your prior notes and adding an update to the file. And that's not going to be sufficient for the FAA. So it is important to try and get your doctors to understand, hey, I need this full amount of detail. Next slide. Now, with that said, many things in life are easier said than done. And this happens to be one of those things. Because going back to what I was saying, this is what doctors were taught in school, but it is not necessarily what they are doing in a daily practice. And so even if the pilot has looked up the guidelines and presented it to their doctor, sometimes it is a little bit difficult to get that note. So what's happening here is that we are asking a busy professional to do something that they don't necessarily feel is necessary. Doctors are typically paid by insurance. So the two things that they are most heavily focused on is protection from liability and getting paid. So those are the two things that when it comes to documentation. So those are the things that they are documenting first and foremost, which may or may not meet the FAA requirements. The better relationship you have with your doctor, the better it is, or the easier it is for you to be able to make them understand or show them what level of detail you need, because this is critical for your career. And that's kind of a big deal. But in general, they're not getting paid anymore to write a more detailed clinical note. So sometimes it can be a little bit difficult to overcome. Next slide. If you hit a brick wall, there are a few other options. One scenario is direct primary care physicians. Now, a primary care physician can write notes for the vast majority of things that the FAA is going to want information on. Certainly, there are going to be times where you need a very specific specialist, a cancer diagnosis, a very specific lung condition is going to need a pulmonologist. But the most common things are going to be able to be handled by a primary care physician. Direct primary care is a relatively new method of doctors who don't take insurance and work directly for the patient. And that's what you're looking for. Somebody who's willing to give you the time that you need to explain what your situation is, do a thorough evaluation, and document properly. So depending on what your issues or concerns are, a direct primary care physician may be the right one for you. Now, again, they don't take insurance, so this is going to be something that's either a fee for service or a monthly subscription type of thing. Now, if you're not ready to make the change to a direct primary care, or you need a specialist, another option is called an independent medical examiner. These are physicians specifically set up to do a comprehensive case review of files to look at the entire history of a medical condition, conduct their own independent evaluation, and then write comprehensive reports. This is something that's frequently done in litigation cases about patients and medical issues. However, there's no reason why you can't hire one yourself. With that in mind, they do not take insurance, and these can get very expensive. Overall, though, if you commit to the process, you can probably get the documentation that you need. Next slide. Historically, 94.5% of pilots leave the exam with their medical. With some rare exceptions, it should never take more than 6 to 9 months to get your medical after a review. Many people with significant but well-controlled conditions will receive their medical within 3 months, even after a deferral, provided that they gave the FAA everything they needed to evaluate at the time of the exam. If you're missing information, it will just take longer. And I bet nearly every one of you who's watching this knows someone who's battled the FAA for more than a year to get their medical. So what's the deal when you hear someone say, I sent them everything that they asked for, but they keep asking for more? The doctors in the FAA Aerospace Medical Certification Division in Oklahoma City are not the ones examining you. They are operating solely on the notes from your physicians provided by your AME, or if you mailed them in yourself. When those notes are incomplete or contradict one another, the reviewing physician in Oklahoma needs additional information to clarify the situation, and that's what generates the request for more information. Doctors' progress notes often fail to identify or address key information that the FAA is looking for or contain outdated information or inaccurate information that just raises more questions. Even as a layperson, you can probably spot a good progress note when you see one, but you might need to see one in comparison to a bad note to be able to spot which one is good and which one is bad. Meanwhile, the FAA wants to know the details about how your condition is, how it's being evaluated, how it's being treated, and they're especially interested in the potential of it to impact you in the near future over the duration of your medical certificate. So letters that say this pilot is fine is simply not good enough. The FAA wants the opinion that you're fine coupled with the actual evidence that you're fine, not just that statement. So if you're responding to a letter from the FAA, make sure you answer it completely. A 90% solution is a 100% failure. Next slide. Let's take a look at a real scenario. So this is an actual client that we had. Say your AME deferred you because you had a new diagnosis of sleep apnea. You did not report sleep apnea on MedExpress because, quote unquote, it wasn't a condition that they asked about. But meanwhile, the AME did ask you about it because it is a mandatory screening item for the AME to check. Because of the backlog of cases, the FAA takes 3 months before they send you a letter and they say, hey, you have 60 days to give us information about your treatment protocol for your sleep apnea. You get an appointment with your sleep specialist, you get all of your documents to ensure you're meeting your CPAP treatment requirements, and your sleep specialist, who also happens to be a neurologist, fills out all the paperwork. It is now 5 months since your exam. You did your exam, took 3 months before you got the letter, took 2 months to get everything done. Now you send all this back into the FAA. Next slide. Meanwhile, it takes another couple of months for the FAA to review your paperwork. In the note provided by your doctor, it mentions under past medical history, migraines. But you've never marked yes to the question 18A about headaches or migraines. Meanwhile, you think back and you saw this doctor 5 years previously when you had a series of bad headaches, but you didn't know that he diagnosed you with migraines, so you never thought to disclose it on MedExpress as history of migraines. But that one word is going to generate a new request from the FAA for an updated evaluation regarding your history of migraines. And because the FAA uses mail to communicate with you, it is now 7 months after your exam when you receive this request. You get the customary 60 days to get this migraine evaluation performed and submitted. Meanwhile, your neurologist doesn't have any openings to get you in, so you go to your primary care physician. He writes his note and you get that submitted right before the 60-day deadline. Next slide. After several more weeks, it rises to the top of the review queue for the FAA, and listed under current medications is Percocet. By month 10, you receive a letter of denial from the FAA for use of narcotic medication. You are at a loss to understand this because you don't know what they're talking about. You're not taking Percocet. So you call AMCD and someone tells you that it was listed under your current medications on that most recent note from your primary care doctor. You think and rack your brain and you're like, how is this possible? But it turns out that you did have an elbow surgery 18 months earlier and you were given 5 days of Percocet, which is a completely reasonable post-operative dose of opioid medication. But because their electronic health record automatically carries over and these doctors happen to work in the same hospital system, that medication was still listed under a current medication. The way most modern electronic health record systems is those medications will just carry over unless somebody manually removes them, and no one manually removed it in this case. So in this case, you tell the AMCD that, hey, I don't take this is from 18 months ago. And so the reviewer that you speak to on the phone says that they will pass this on to the duty flight surgeon. A few weeks later, you get another letter from the FAA requesting a status update from your treating physician on your historical use of Percocet, because they're not just going to take your word for it, and copies of pharmacy records with, again, 60 days to comply. Because of schedule conflicts, you can't get in with your doctor in time, but their PA has an opening for you. The PA writes you the note, you get the pharmacy records, and by month 12, you send everything in. Next slide. More than a year after your exam, with your airplane just sitting in the hangar or your job long gone by this point, you get another letter from the FAA stating that they received your pharmacy records, but they are again requesting a note from your treating physician regarding your use of Percocet. And you are starting to lose your mind because you don't understand what is happening. This is a real case from a real client of ours who contacted us after this last letter. Now, I want to go ahead and highlight some of the issues. First of all, the pilot didn't disclose sleep apnea because he didn't think it was reportable. Then the AME deferred the exam when he could have assessed what treatment protocol the pilot was on and likely issued the certificate with the pilot having 90 days to supply the appropriate medical records. But that's not what happened. So the pilot made an error and the AME made an error. But theoretically, the pilot should have walked out of his exam with his medical certificate at that time. Now, moving forward, the note from the sleep specialist disclosed a medical condition of significant concern to the FAA, but the pilot had not previously disclosed it, partly because they weren't aware. So it is important to be aware of what is in your medical records. Had the pilot known about the diagnosis of migraines, reported it 5 years earlier, marked it on every exam, and had the correct update for every exam, this would have been the end, and the pilot would have received their certificate at that 7-month mark. The second issue was a simple clerical error that resulted in an extra 6+ months of delay. Basically, every time the FAA asks a question, it's about a 3-month turnaround. So why was it 6 months? Well, that's the third issue. The FAA doesn't take notes from PAs or nurse practitioners. They want notes from doctors, and that's it. And they're not really going to budge on that. They only want to hear from a physician. So that's why the second request about the status update regarding Percocet came in, because the original note was not from a physician. So this pilot should have been issued at his exam, should have been issued after providing the sleep apnea paperwork, should have been issued after providing the migraine paperwork, and then should have been issued again after providing the Percocet paperwork. But a series of small errors popped up at every single interval, resulting in this significant delay. Next slide. The guide for aviation medical examiners is publicly available on the FAA's website. If you're wondering how the FAA may react to your particular medical condition, feel free to look it up. Shameless plug, we also have a blog where we cover lots of medical conditions and we talk about each one. Not all medical conditions, but we still publish new articles every couple of weeks. So do some study like you would for a Checkride. Just know that it is written for doctors, so you may not completely understand it, but you can bring the appropriate sections to your doctor and discuss them. It also only covers the more common issues, which seems a little strange because it's several hundred pages long, but there are a lot of medical conditions out there, so it doesn't cover everything. Another major factor is choosing a competent AME. Now, you might think, well, aren't all doctors the same? But I ask you to think, is every pilot you know an excellent pilot? Or do you know some pilots that you would rather not fly with? Well, the same is true for really any profession that's out there, and it is true for AMEs as well. Not all AMEs are actually very good at their job. So if you don't go to an AME that's competent and knows what they're doing, you are just asking for trouble, particularly if you have something important to disclose. Now, that AME that gets you in and out might seem great, except that guy who gets you in and out in 5 minutes and doesn't actually do a thorough exam and doesn't actually do the urine test and doesn't actually listen to your heart, that guy's not going to know how to help you when you have a real problem. So it's worth having an established relationship with a competent AME. The other thing is that, at Wingman Med, we feel it is better to do things the right way the first time and never have to look over your shoulder wondering if this is going to come back and bite you. And I say that because there have been times where that, quick in and out AME has lost his privileges as an AME because people found out what was going on. And then every pilot in the last 2 years who had an exam with that individual has been given 60 or 90 days to get a new exam. Well, that can be complicated if you're out of the country or if your work commitments make it difficult. So overall, our goal is to keep you flying, and whether we provide that information via our blog or our medication database, or you need more detailed help, that's what we're here for, is to keep you flying. Next slide. All right, so I'm open for questions.
Okay. Well, those of you who are viewing right now, you could click on the button at the lower portion of your screen. It says Q&A. You could type in a question or make a comment. And, we would be happy to ask Dr. Roxo about that. And then we may not get to all of the questions, but I have one. Um, what if, how does the FAA look upon, say, if you've had AFib, and then you're taking medication to deal with that?
So the number one thing about AFib that's a concern is, well, let's go back to that sudden or insidious incapacitation. So one of the biggest concerns about atrial fibrillation is the stroke risk. So as your heart is in atrial fibrillation, you can develop a blood clot in your heart. And then if you come out of AFib, either spontaneously or through treatment, now it can send a clot up to your brain. And so there are some people who have what is called paroxysmal AFib, where they'll go in and out on their own. So if they go in for a longer period and then come out, there's that stroke risk. So the important thing about AFib is to, number one, mitigate the stroke risk, and then they want to look for any underlying structural damage. Sometimes people have just an electrical conduction issue, and that causes the atrial fibrillation. But sometimes atrial fibrillation is the result of an overstressed heart because there's a valve problem or they have sleep apnea. We get that question a lot. I have AFib. Why do they want me to get a sleep study? Well, there's a pretty high risk of atrial fibrillation secondary to long-standing untreated sleep apnea. So if you have atrial fibrillation, they need you to prove that you don't have sleep apnea. But overall, whether you have it controlled with medication or you have an electrical ablation, but really, if you can show that your heart is structurally sound and the AFib is under control, and that any potential causes that are concerning have been ruled out or addressed, you can fly after atrial fibrillation.
In your experience, maybe not personally, but who's the oldest pilot that's ever passed a medical? I guess when you start getting into your 80s and 90s, that may be of concern.
Yeah, and I don't know off the top of my head. I know that we have many clients in their early to mid 70s that we still help maintain an FAA medical. And some of them have had significant medical issues in their past, including heart attacks and strokes, recurrent brain tumor. And so we tell them like, hey, if you want to keep flying, we give them the long list of things that they need to do, and they work with their doctors and they do it. And when you can show the FAA with high quality medical documentation that your risks are mitigated, they will give you your certificate.
Okay, well, that's encouraging. I'm not 80 years old yet, but anyway.
It does take work though. It does when you start, the more medical conditions that stack up, the more work it takes. So our best advice is to be as healthy as possible.
For sure. Well, I've known some pilots who are, they're pushing 80, and for them, the insurance is the issue.
Yes. And that's something that we have heard, anecdotally or directly from individuals. And it does seem to be, you know, age plus complexity is going to start running into more and more issues. So, if you're 70 and you're flying a Cessna 182, so you have fixed gear, it's probably a lot easier to get your medical than if you're, 70 and you're flying a multi-engine retractable aircraft, because now the risks have gone up dramatically. And so we have heard from numerous people within the industry and just, individual aviators that at a certain point, whether it's age or complexity, the insurance is saying, no, now we want you to have an FAA medical, and basic med is not good enough. You'll see fights on various internet groups about that. But then when you start really digging down, it's like, okay, well, again, you fly a Cirrus SR-22 with fixed gear, and I'm instructing in a multi-engine Baron. There's a difference between the risk mitigation and the insurance companies at that point.
Right, right. Well, we do have some questions. PJ, I'm not seeing those on my screen, but everything you're talking about is pretty interesting. So anything else that you wanted to tell us about? Again, the Boy Scout. So the Boy Scout thing, that their mantra is be prepared, be
Right.
prepared. So
Right. Yeah. So I think I was able to pull up the Q&A. It says, one of the questions is, are there some common medications that will be immediately disqualifying if they are used regularly? Yes, absolutely. So anything narcotic used regularly, absolutely disqualifying. You're actually disqualified while you're taking it, even if it's for a short duration. Again, if you accidentally smash your hand with a hammer working on a home improvement project, it's perfectly reasonable to get a couple days of, Percocet. Um, and no, you do not have to disclose that at your next exam as long as you are no longer taking it. But while you're taking that medication, you are grounded because it is an impairing medication. So that's about the most I can say with that question. We do have a couple of articles on our blog specifically about sedating medications or other medications that can be complicated. And we even have one of our articles talks about the math about if you have a certain medication, how long do you have to wait before you're allowed to fly? And so we kind of have the math formulas in there. And the FAA does have some specific guidance as well. But anything that's concerning for cognitive impairment or sedation is going to be disqualifying for use. Now, again, some of those are over the counter, like I mentioned, Benadryl. Some of those are not over the counter. A good one I'll bring up here is gabapentin. Gabapentin is more commonly being used for a pain medication, but that's not what it was FAA approved for. It's FAA approved as an anti-seizure medication. So there's two problems with taking an anti-seizure medication. Number one is seizure medication is designed to slow down signal processing in the brain. That does not sound like something the FAA wants, is a slowed down brain flying. The other thing is, are you hiding a seizure condition? Right? Oh no, don't worry, I don't have a seizure condition. I'm taking gabapentin for my nerve pain. Okay. Well, there are other medications for nerve pain that can be approved, or the FAA would rather have you get your nerve pain under control by treating the underlying cause of that nerve pain rather than taking a anti-seizure medication on a regular basis. But we do have on our website a couple of blog articles. We also have a medication lookup tool. AOPA also has a medication lookup tool as well. But the FAA unfortunately does not publish a very specific list of approved and not approved medications. Another question, been prescribed tramadol for arthritis. Even when I was flying on active duty, I still take it. Yes, that is a disaster for a medical certificate. Tramadol is a controlled substance, so that is not authorized. So I would recommend talking with your doctors about, hey, what alternative medications can I use or what alternative treatments can I be on to mitigate my need to be on a controlled medication, because that will prevent your FAA medical certification. All right, next question. As a military veteran, 100% permanent and total disabled, do you recommend shopping around for a specific AME that knows how to tackle the new VA FAA requirements? So first of all, there are no new VA FAA requirements. You have always been required to disclose any disabilities, whether they're VA disabilities or Social Security disabilities. So there's no new requirements. The only real new requirement is because of what happened in the last several years, which was not the FAA's fault. The VA basically took a bunch of records and dropped it on the desk of the FAA and said, by the way, did you know these people have these disabilities? And so the FAA was kind of left with no choice where they would look at files and say, okay, the VA is giving this guy medication for depression and he's never told us about it. And so that became a problem. Most of the time it was not intentional. Most of the time it was I told the AME, but the AME never told the FAA. That was a very big part of that situation. But in general, you do have to provide a copy of your VA rating decision letter, which is going to list all of the conditions. Keep in mind, conditions that were also denied or at 0% may still require explanation. We had a gentleman not too long ago say, I don't understand why the FAA is asking me about rectal bleeding. Well, he had submitted a claim for rectal bleeding. It was denied. Denied does not necessarily mean you don't have that medical condition. Denied means that the VA is not taking responsibility for it. So if you felt that your rectal bleeding was important enough to ask for money from the federal government, you better believe that the FAA thinks it's important enough to want more information about it. So what I would recommend is, in that case, identify what the real issues are and look up how each issue needs to be addressed. And then if you are in the mandatory deferral requirement, it doesn't really matter what AME you go to. If you have to be deferred, you have to be deferred. If you start entering the gray zone of I can be issued so long as I have all the right documentation and my AME knows what they're doing, then yes, you want to shop around for an AME that knows what they're doing. Some good questions to ask of an AME. Are you a member of the Aerospace Medical Association? Are you a member of the Civil Aviation Medical Association? How often do you attend recurrent training for the FAA? It's a minimum every 3 years, but I go at least 3 times a year as opposed to once every 3 years. How often do you handle complicated cases? How often do you attend the AME grand rounds? Hint, they're monthly. So if they say, what are the AME grand rounds? They probably don't know what they're doing. So that's the question about disability. See, there's another question about 0.75 melanoma removed. So with melanoma, there's a specific number. I'm going to look over at my other screen right now to look it up because I know
So that's skin cancer.
that is skin cancer. So 0.75 is actually the depth of importance when it comes to melanoma. So if it is less than 0.75, then it's kind of easy, right? You have to be able to provide the documentation. But at 0.75 or greater, it becomes a bigger deal, right? So it's important to have that documentation. And the reason for that is once the melanoma is greater than 0.75 millimeters deep, it now has a significant risk of metastasis. And as we've had this question before, why is the FAA making me get a brain scan for my skin cancer? Well, melanoma likes to go to the brain. And so that is where it likes to metastasize. So that's what they need to rule out is metastatic, cancer to the brain. So overall, your question says 0.75. So I think it's very important to determine what exactly was the measured depth, and then I would be able to better answer that question. Next question, in a reverse shoulder replacement surgery and automatic, no. Okay, here, joint things overall. What's interesting about joint things overall is that the AME has the ability to evaluate certain things right there in the exam. And joint things are one of those things that's fairly easy to evaluate as part of a physical exam. More complicated mental health issues are harder. More complicated internal diseases are harder to evaluate in the exam. So those things generally require outside supporting records. But with a joint replacement surgery or any other major joint problem, maybe not replacement, but a surgery related to a joint, if you can demonstrate good functional capability within the exam, then that AME can make that disposition himself right there in the exam. Now, if you are concerned about that, or if you do have a significant functional limitation, then it's a good idea to have a note from your treating doctor about specifically and exactly what are those limitations, whether they're range of motion or strength. And that will be more evidence for the FAA to be able to determine. But if you do have a significant range of motion limitation or a significant weakness, that would have to go to the FAA for further review.
Dr. Roxo, there's been a lot of discussion in the last couple of years about mental health with pilots.
Yes.
And so, I've heard everything from anxiety, all of that. And it seems like the FAA's position is evolving on that.
Yes.
Would you agree?
So I would agree that they're evolving, but I would also agree that people's interpretation of the FAA stance is not realistic. And in general, the FAA is evolving in that they are now allowing the AME to disposition more things with quality documentation, and that is great. That helps out a lot of people. And the reason why I say that some people's interpretation of how the FAA looks at things is not correct is that all you have to do is replace whatever mental health diagnosis you're talking about with heart disease, and you will start to see why the FAA acts the way they do. So mental health is not necessarily a one-time thing. It is a potential, not always, but a potential chronic recurrent illness. And the other thing is that this is largely a product, in modern times, this is largely a product of insurance paid doctors, right? And this is not to badmouth the doctors themselves, but let's say let's say you had a period that you struggled with and you went to the doctor for help, but you didn't pay for it because you wanted insurance to pay for it. that doctor's going to diagnose you with something, because if he doesn't diagnose you with something, how's he going to get paid? So that practice is designed to make money. That practice is going to diagnose you with the most significant thing that they can bill to get paid. So now you may have, you may have an issue that you would like help with. That doesn't necessarily mean you have a disorder. But as soon as it's labeled by a doctor as a disorder, that would be like going to the doctor because you had a little bit of chest pain and they misdiagnosed you with heart disease. So if the doctor misdiagnoses you with heart disease, oh, you better believe the FAA wants to know about your heart disease. So you just have to replace any mental health condition with heart disease, and you'll see why the FAA wants to know more about it. If you've had recurrent episodes of heart disease in the last 10 years or recurrent episodes of minor depression in the last 10 years, the FAA really wants to know, how are you doing? And so it really depends on the level. So once you trigger, if it's been relatively recent or it's more severe, well, then they want more information and more professional, higher level evaluations. Same thing. They're not going to let your primary care doctor clear you from heart disease. You have to go see a cardiologist. So if you have been diagnosed with major depression, they're not going to let your primary care doctor clear you from that. They want you to see a psychiatrist. So the parallel is almost exact.
Okay. I know that's been in the news a lot in the last couple of years. And so we have time for one more question. This one from Mr. Gallagher. How much information about a pilot's medical can an AME provide to the pilot's chief pilot or director of operations?
So the AME should be providing absolutely nothing to anybody other than the FAA and the pilot. If there's a company that has a doctor on staff, well, that would be a little bit different. And, I actually don't know what the official rules would be like of that. But Chuck, if you came to me for an exam, I'm talking to you and I'm talking to the FAA. I'm not talking to anybody else. And I shouldn't be talking to anybody else unless you give me permission to.
Okay. All right. Well, I appreciate it very much. Well, this has been very informative, and really, really appreciate everything you've talked about is so practical. And again, this recording of this webinar will be available on our website. So I just can't thank you enough for being a part of this. Anyway, just a couple of things in closing. We encourage you to become a member at Vertical Aviation International. You can go to our website, which is listed right up here on the screen, verticalavi.org. When you're a member, you get a copy of Power Up magazine, which comes every quarter, and it's full of interesting information. And then the other thing is we have like an e-newsletter that comes 5 days a week, Monday through Friday, about things happening in the world of vertical aviation. And for me, it's a habit. I check it every day because there's always something interesting in there that I find I want to know more about. So how can we help as an organization? Well, you can contact our president, and the email address is president@verticalavi.org with any challenges you may have. We're here for you. We're here to serve our members, and we would love to have you as a member. So we're concluding this webinar. Before we go, I wanted to say that this webinar is produced by Bailey Wood with technical assistance from PJ Barber and Jay Clark. A special thanks to Chris DeJoy, Shauna Kearns, Gina Kvitkovich, and the amazing writer Jen Boye for publishing the fact that this was going to happen. Thank you, Dr. Roxo, again, and thank you all for viewing this webinar.